Welcome back to yet another round of fertility Q&A with Dr. Rohit Gudgutia, powered by IVFICSI.com. This series is designed to help couples navigate their journey to parenthood with informed guidance. In this episode and the next, we will be exploring the various fertility assessment options available for men and women. So if you are one of those couples who are wondering or trying to understand what are the tests that you might have to undergo as part of your fertility evaluation, do tune in with us in this episode and next. Dr. Rohit, welcome back to the series again. Doctor, in our previous episode, we discussed about pro-fertility counseling and how it is beneficial for couples who are planning to start their family on their own. And one of the aspects or one of the steps in this pro-fertility counseling we discussed was that they have to undergo fertility assessment. Even for couples who are seeking fertility treatment, fertility assessment becomes the fundamental starting point. So, doctor, could you please elaborate on what are the objectives behind fertility assessment?
So, to put it very simply, when we are talking about a couple getting pregnant, we want them to get pregnant and deliver a healthy child. So, we need to know whether all the parameters are in place for a healthy pregnancy to happen and a healthy child to be born. So, this is the objective with which you start to investigate that couple and find out whether they are fit enough to carry a pregnancy, get pregnant and then carry a pregnancy to natural outcome of a healthy child. So, this is the objective that you start working with.
When would you recommend couples to go for this fertility evaluation?
Yes, so we have been talking about this and we talked about pro-fertility counseling in our previous episode. So, the couple, when they have decided that they want to become parents and they want to know whether they are fit enough to become parents or not, that's when we recommend a fertility assessment test. It will be of interest for you to note that now some corporates are asking for fertility testing as a part of their general health checkup as well.
Oh, wow.
When they are doing the pre-employment checkups. But in our context, when we discuss about pro-fertility counseling or we discuss about fertility assessment, we are essentially dealing with a couple who has now decided to become parents, and that's when we recommend the fertility assessment.
So, doctor, focusing on female fertility assessment for this episode, how do you assess for female fertility? What are the causes for infertility in women? And how does these tests help in identifying these causes?
So, let's start with common sense first. So, it's expected that people will get pregnant unless there is some very obvious reason for them to not get pregnant. So, fertility or the ability to give birth or to become parents is a given. We would assume that all couples are healthy enough to become parents unless otherwise proved. So, starting with this assumption, what we would recommend is that any woman who is planning to become pregnant, she should go for a general health checkup first, because she should be fit enough to be able to carry a pregnancy. That's very, very important.
Makes sense.
And when we talk about fertility assessment, we somehow do not give enough importance to the overall health of that person concerned. So yes, we need an overall health assessment of that person concerned, and then we talk about more specifically about her reproductive health or her fertility status. So, in the course of today's discussion, we will definitely understand what we mean by reproductive health, but for starters, the general condition that we are talking about is, let's say her heart, her lungs, her liver, her kidney should be functional enough to be able to support the pregnancy. So, that's a very basic thing. We check for her sugar status, we check for her blood pressures, we also look at her hormonal level like her thyroid status. So, these are some things that are essentially carried out for all women when they are planning a pregnancy. We also check for the blood group because there are blood group related issues as well. We also look for her hemoglobin and her nutritional status, and coupled with that, nowadays that we are recommending a pre-pregnancy thalassemia screening. Actually, that's one test that you should carry out at the time of getting married. Because if you do have the risk of thalassemia because you have thalassemia running in your family, then it's very, very important that you do the test for your partner, and then you do understand that if each of you or either of you is carrying a risk, then you need to counsel properly with the counselor who will tell you what are the risks of your offspring carrying that disease, and this is something which is very, very basic, very fundamental, and this would I would say this would comprise what is known as a general overall health checkup of the person concerned before she plans her pregnancy, and then we go into more details about the reproductive health.
So, moving on to the part of reproductive health, what are the areas in a woman's reproductive system that you would be assessing for through these tests?
Yeah, so most specifically when we talk about the reproductive health, we are most concerned or most worried about her egg quality, because a pregnancy is essentially the egg and the sperm fused together, the embryo, and the most important component of a pregnancy is the maternal egg. So we are interested about the egg status, and then of course the womb, the uterus, whether it can carry a pregnancy or not, and the next in line would be the fallopian tubes. They are healthy enough and functional enough for the pregnancy to happen naturally. So in that order, we would first assess her for her eggs, the quality of the eggs, the quantity of eggs, and then we will look at her womb, and then at the last in the pecking order is we look for the fallopian tube. If all three are in order and her reproductive health otherwise is also good, she has regular cycles, plus her general health being all right, then we would classify her as a low risk or a patient or a person who can easily get pregnant.
So starting with the pecking order, how would you test for the ovarian function?
Okay, so this is something of interest for all of you to know, that a woman is blessed with a fixed number of eggs, and she does not make her eggs as it were every month, and she uses her eggs that are present in her ovaries since birth. So every month that she menstruates, she uses almost 1,000 eggs, of which one egg would mature and become the dominant egg for that particular month, and that egg may or may not give us a pregnancy, and the other eggs would all die off. They would be wasted by the body. Such is the design of the body. So when we look at the reproductive health of a person concerned, the female partner, we are very much concerned about her overall ovarian reserve, meaning how many eggs are still available in her ovaries. The basic principle underlying this thought is that we have a sense that women who have lot of eggs in their ovaries tend to have lot more better quality eggs than those women who have lot less eggs in their ovaries. So definitely somebody who has lot of eggs in her ovaries have a lot of time on her hand to plan her pregnancy, vis-a-vis somebody who has less eggs and therefore she has less time to plan her pregnancies. Also, we think that women with lot of eggs have a much higher chance of a healthier pregnancy as opposed to somebody who has lot less eggs, because we feel that over time the good eggs may have been exhausted and the eggs that are still left behind in the ovary may not be very good. How do we check for that? So previously what we used to do, we used to do a blood test, a serum blood test called Follicle-Stimulating Hormone levels, and that was carried out usually on the second or the third day of a spontaneous menstrual cycle. But now we've discontinued that because this test is very variable. It has to be done on a fixed day in the menstrual cycle, and the values change with medication. So we've now discontinued looking at ovarian function or ovarian reserve with the help of this test. There's a much more popular test these days which is known as serum Anti-Müllerian Hormone level, so AMH test. I'm sure you've heard of it. So AMH is a much more standardized test, can be carried out on any day of the cycle, and this gives us a very fair estimate of her ovarian reserve. A much better test in that sense would be doing an ultrasound, a transvaginal ultrasound, to assess the number of eggs that can be seen with the ultrasound machine on her second or the third day of the menses. But this being an invasive test, we reserve this test only for women who are into active fertility treatment. But for most women who are starting out and would like to have a sense of their reproductive status, a blood test called AMH is the best test that you can do, and you will get a very good idea about your ovarian status. Again, this is for information rather than for anything else. A value which is anywhere between 2 to 3 nanogram per ml would be a good value for you to consider. Any value which is more than this which basically would suggest that you have a lot of eggs in your ovary, and a value less than this would suggest that you have less eggs in your ovary and you should think of planning a pregnancy quicker. So that would be a basic understanding or suggestion for you to look at your ovarian reserve.
Moving on to the testing of the tubes, what are the tests available for testing tubes?
See, tubes are very poorly understood structures. A fallopian tube, in fact a person has two fallopian tubes. The fallopian tubes have three functions. they have actually got to go actively and pick up the egg. So that's the first function. They have to allow the sperms unhindered access to the egg. So that's the second function. And then once the egg and the sperm has united to form an embryo, they have to alternately contract and relax to push the embryo back from the tube into the womb. So these are the three functions that a tube has to carry out, and all three of them are equally important. Unfortunately, tubes are hollow structures. At one end they are attached to the uterus, the other end is free, by which they can pick up the egg. That end has finger-like projections, we call them fimbriae. Now unfortunately, when we talk of assessment of tubes, we can only assess them for a particular function, and that is whether they are blocked or not. We are not able to assess them whether they can actively go out and pick up the egg, neither can we assess them today about their ability to push the embryo back from the tube into the womb. So when we talk about tubal assessment, we talk about partial assessment. We cannot fully assess the tube. As somebody senior told me once recently, that we can look for tubes patency and not for tubes potency. So that's something we have to remember. How do we do that? So there is imaging. We either do an X-ray or we take the help of an ultrasound. The principle is the same. We push some water, which could be mixed with a dye, and then water is pushed into the womb. Through the womb it flows into the tube, and from the tube it falls into the tummy in the abdominal cavity. You can either pick up the flow of the water through the uterus and the tubes into the tummy with the help of an ultrasound. That's a real-time imaging of the womb and the tubes, and will give you very good information about the tubes are patent or not. Or you could do an X-ray before you push the dye and after you've pushed the dye, so that you know whether the tubes can be seen in its entirety and whether the dye can be seen to have collected into the abdominal cavity, and therefore you know that the tubes are open or not. There's a third method called laparoscopy, where you actually put a camera in the tummy through a hole through the nevus, and there you check for the flow of the water into the tummy real time with your own eyes. This is the most reliable method, and we call it the gold standard method. This is laparoscopic chromopertubation. The principle is the same in all of these. We check for the flow of fluid from the tubes into the abdominal cavity and come back and tell you whether tubes are open or not. What we cannot tell you, and this is very important for my viewers to know, is that we cannot tell you whether the tubes can actively go and pick up the egg or not. Neither can we tell you that the tubes can functionally push the embryo back from the place of fertilization to the womb. So this is something that we have to remember. So whenever somebody is told that her tubes are fine, what we are trying to tell you is that tubes are patent, they are open. But we can't, for heaven's sake, we cannot come back and tell you whether they are fine in its totality, because we cannot check for their ability to pick up the egg or to push the baby back into womb. Why do we need to know this? Because we need to understand that medical science cannot really assess anything fully. Even when we talked about the eggs, we have to understand that we can only talk about the egg quantity. And when we talk of quality of the eggs, it's an inference. We assume that the quality should be good if the count is good. We don't have proof of that. And this is a very strong message here, that in medical science we cannot be sure of what we are talking about.
Doctor, thank you for clarifying this with such clarity. If a couple is unable to conceive, the usual stigma in India is that they blame it to the womb. So what are the tests that can help a woman find out if her womb is fit for a pregnancy or not?
Again, this is so important for you to bring this up. So often we get to hear from couples who have failed to conceive, as you put it very correctly, or have miscarried unfortunately, and somehow it's all put down to the womb. So first of all, please understand, Jyotimai and also all of you, that the womb is the most blamed but the least responsible organ as far as infertility is concerned. The womb, I would say, is the most loyal organ. Very rarely does the womb not allow a pregnancy to implant or continue. The womb is a structure, it's a muscular structure. It is so small when it is not pregnant, and it is this big when it is pregnant. So the womb is basically a storage organ where the baby can implant and then continue to grow. The womb usually does not go wrong. Yes, there are fibroids that might happen in the womb. These are basically muscular outgrowths, and they may affect almost 1 in 3 women. But again, thankfully, most of these fibroids do not in fact affect the pregnancy in any which way. You find out that the woman has fibroids only when you are actually doing the surgery to remove the pregnancy during a C-section or something to take out the baby. In most circumstances, the fibroids may be there, but they do not affect the ability to hold a pregnancy. Rarely the fibroid may be in a location that the pregnancy may not implant. How do you check for this? So a simple ultrasound carried out through the transvaginal route will give you a very good information about the womb. If you're not happy, not satisfied, you can do a hysteroscopy. That is, you put a camera inside the womb through the natural orifice. You don't have to cut open anywhere. And then that camera can actually look into the crevices of the womb lining in great details and come back and tell you about the womb health in finite details. So a hysteroscopy or an ultrasound are equally good to give you a lot of information about the womb being healthy or not. Again, luckily for us, the womb is almost never responsible for infertility. So that's one organ we can safely take as something that's not going to affect us.
So what other blood work may be advised in addition to the tests that you have mentioned?
So again, that all depends on the kind of patients that we're dealing with, but in most circumstances, a general health checkup as we mentioned, and then a blood for AMH and a transvaginal ultrasound combined with checking of the fallopian tubes. We call it a sonosalpingogram or SIS, saline infusion sonography. That's good enough to be aware of the fertility or the reproductive status of that woman. We do not need any other further workups. But yes, we do patients who have had multiple miscarriages, who have been treated elsewhere with multiple failure cycles. So in those few patients, those niche category patients, we have to check for their genetics, whether their reproductive health is somehow affected by their genetic makeup. There could be something wrong with their genes. We might also have to look for some specialized antibodies in the blood system which are affecting her ability to carry a pregnancy or to become pregnant. But these are very few instances. In most circumstances, what we discussed so far is good enough.
Doctor, from your countless female fertility evaluations that you have assessed over the years, I'm quite curious to find out what kind of trends have you noticed in the investigation findings? What is the most common cause of infertility in women, and how does this change with age?
So when we were studying in our colleges, we were told or made to understand that tubal infertility is the commonest infertility, which is quite understandable because 50 years back there were young couples, they used to get pregnant earlier, so there were a lot less egg factor involved, and people who did not have pregnancies, usually they had some underlying infection affecting their tubes. But after we started practicing, that's around 20 years back, and today even more so, most couples that we see, if they do have female infertility, and please understand there are more couples with male infertility than female infertility that we see today, and that's the unfortunate reality. The women who do not get pregnant because of a problem affecting them, in most circumstances it's neither the womb nor the tube. It is the fact that they have come for a pregnancy or they are trying for a pregnancy so much later in the day that her egg reserve has now been exhausted. So if you were to ask me, the trend that we have seen is over time more and more people are coming to us with infertility, where the real problem is that age related processes have affected the ovarian reserve, the egg quality, and which is why they are finding it difficult to get pregnant. We really can't call this a disease also, because this is a natural decline in fertility that happens with age. So this is a problem that we are grappling with, and some call it an epidemic also, because you have no idea how many women are now suffering from this simply because they've started too late in the day trying for a pregnancy. So this is a trend, if you could call it, that I wanted to highlight today. Thank you for asking this question.
My pleasure, doctor. Doctor, what is your approach towards couples who have already had a fertility assessment done previously before they come to you, and do they need to again undergo these assessments?
Again, a very valid question, Jyotimay. See, the point is, people come to us with sheafs of paper, thick files, and the last thing that they want to do is to repeat their tests with us again and again. And in most circumstances, we do not want to repeat the tests also, especially the general assessment tests need not be repeated. You are not going to change your blood group, are you? So if you've checked your blood group once or your thalassemia status once, you need not check it once again, and that's very, very important. At the same time, how do you know that person? The only way that we can know that person is through a transvaginal ultrasound. So that's one test, and that doesn't need any kind of an intervention. There's no blood test as such. A transvaginal ultrasound is what helps us understand the female pelvis, and this gives us a lot of information. Some of it may not have come through in previous assessments, and this is highly individualized. We all feel comfortable. I'm speaking for all my colleagues here. We all feel comfortable when we do our own ultrasounds. We get to see the pelvis with our own eyes. We get a sense of the pelvis, the ovarian status, the alignment of the ovaries with the uterus, the angle of the uterus, the shape of the uterus, the endometrium lining, the alignment of the uterus with other organs in the lower abdomen. All that helps us get a provisional diagnosis in our minds, and this helps us chart a course for this person. So one test that we would of course repeat is the transvaginal ultrasound. Believe me, there is no other test that needs to be repeated, unless of course she is diabetic and we are starting a treatment, in which case of course we would want a fresh sugar assessment and some such test. But in most circumstances, it's just the TVS that needs to be repeated.
So you would repeat the tests that are needed to assess the current status?
That's it.
That's it. So coming to the part of genetic testing, so what are the genetic testings that couple might have to undergo? Again,
see, point is, as we become more aware of the whole process of reproduction and our knowledge enhances in this branch of medicine, we get to understand that we are all made up of huge number of genes, and none of us are healthy in the sense that none of us have a completely healthy set of genes. All of us are carrying mutations or defects in our genetic makeup, but thankfully these defects are existing in one of the genes and not in the other gene, and which is why we are not getting affected that sense. So these are known as recessive or the dormant mutations. Now, when two people get married and they both carry the same kind of mutation, then there's a significant risk that their offspring may also express that disease. So that's when checking for these mutations or these defects becomes important. So most cases when a couple comes to us with primary infertility, have never been pregnant before, and they do not seem to have any egg quality or a sperm quality issue, are of normal habitus, the height, the body structure, everything seems okay, their IQ seems okay, we do not ask for any kind of a genetic or chromosomal test. So this is not a test of first line. However, if someone does come to us with multiple miscarriages, multiple IVF cycle failures, some sort of a clue in their body habitus, their height, their body structure, their way of speaking, their IQs, and if they show abnormally less number of eggs or sperms in their egg report or sperm report, which is not matching with their body structure, then we have to ask for chromosomal assessment or genetic assessment for such couples. So as of today, these assessments are not carried out as routine, but only in a second line subjects where we have reasons to suspect that there could be something wrong with them.
Thank you, doctor, for clarifying why and when genetic tests are advised to the couples. My last question would be, I've come across a lot of couples and queries where they have they've been trying to conceive for a while, they have miscarried, or they've undergone an IVI cycle or an IVF cycle and they've experienced failures. So when these kind of couples are planning for the next pregnancy, what kind of investigations they would have to carry out?
So yes, this is also true, Jyotirmay. There are some couples who do not get pregnant even if they have tried procedures. So these are the unfortunate, let's say, failed treatment cycle patients, and they need a whole set of investigations where they're completely removed from the standard set that we've discussed. This could be the thesis topic for some other episode maybe, but to talk in short, in summary, when we have failed to get them pregnant with standard IVF cycles, we need to worry that the embryo quality may not be good, and therefore we need to subject the embryo to super tests such as whether the embryo is metabolically healthy or is genetically healthy or not. So there is a test to check the embryos called PGT, or pre-implantation genetic testing of the embryos. Then we need to check whether the womb is receptive or not, and there is a test called endometrial receptivity analysis. So that's a test to carry out to find out if the womb lining was receptive at the time of embryo transfer or not. So then again, there are tests which try and find out whether the female partner is immunologically healthy or not, whether she is in a situation where she can carry a pregnancy without harming the pregnancy itself in any way or not. So these are specialized tests. We do not really know whether they are needed or not. They do bring us some information, but many times we are not able to know what to do with that information either. So we discuss these tests with our patients. We explain the pros and the cons of these tests, and if the couple desires to know, because there is an intense desire to know from the other end also what made them go wrong, what was the reason why the cycle failed. So in those circumstances, these tests are carried out, and we reserve them as of now only for failed cases. So
that makes sense. Thank you, doctor, for another very interesting and engaging session on assessments. Thank you for tuning into the session on fertility assessment for the female partner. I hope we have answered all the questions that you might be having on the assessment of female partner. If you have any further questions, do visit our website www.ivfandicsi.com. In our next episode, we will be moving on and covering the fertility assessments for the male partner. So tune in with us, and till then, take care.